Welcome everyone to another Vasculitis Foundation educational webinar. I'm going to talk slowly to allow 99 people to come in because that's what it looks like, or in our waiting room. So we're welcoming everyone to this Vasculitis Foundation webinar. And today's topic is ears, nose, throat, and airway issues with vasculitis. I'm Kathy Olewski. I'm the host for the Vasculitis Foundation educational webinar series, and I'm also a patient living with MPA-ANCA vasculitis. And we're going to begin the webinar. We're going to begin the webinar today with our guest speaker, Dr. Robert Lebovics. And I just want to remind everyone as you come in, if you would please mute yourself if you're not already muted, because that helps us hear Dr. Lebovics when he's talking today. Dr. Lebovics is an internationally known otolaryngologist who focuses on autoimmune and inflammatory diseases affecting the upper airways, head, and neck region. He received his medical degree from the State University of New York Downstate Medical Center in Brooklyn, New York, and completed otolaryngology training at the Albert Einstein Montefiore Hospital Medical Center in Bronx, New York. He recently joined the Department of Surgery at JFK University Medical Center. But prior to his appointment at JFK University Medical Center, Dr. Lebovics was the Chief of Clinical Otolaryngology Service at the National Institutes of Health in Bethesda, Maryland, where he worked with the National Institute of Deafness and Communication Disorders. He was also a faculty member at Georgetown University. And until March 2023, Dr. Lebovics was an associate professor of otolaryngology, head and neck surgery at Mount Sinai Itchen School of Medicine, as well as the site chairman of otolaryngology at the Mount Sinai West Hospital in New York City. And he serves on the medical advisory board for the Vasculitis Foundation. Well, that was a lot, but welcome, Dr. Lebovics. We're so happy to have you here today. And we also will see two other faces in our webinar series today, because we always like to bring the patient perspective to the series. So we're going to welcome Victor James and Cheryl Haggard, and I'll tell you a little bit more about them after we hear from Dr. Lebovics. And if all goes well now, Dr. Lebovics is going to unmute, and I'm going to attempt to share my screen so that we can see his PowerPoint. All right, we should be good. And you're, Dr. Lebovics, it's all on you now.
Well, thank you so much, Kathy. And I just want to say thank you to everybody, mostly to the patients here. I always find this to be both an honor and a pleasure. Maybe a little old-fashioned, but I think part of being a good physician isn't not only treating, but it's learning, it's researching and educating. And if I can impart some of my experiences and background and knowledge of this with the group here, and people have more just know what's going on, it's tremendously valuable. Whenever I meet a new patient, I often with GPA Wegener's, I often tell them, and I quote, knowledge is power. That's part of my when I try to get them to get involved with the Vasculitis Foundation. Because when you have to be part of the solution and you have to learn, and sometimes patients know more than their doctors. The fact that you're all here is really all to your credit. I'm very humbled. As I planned this discussion, this webinar with the group here, there'll be about 15, 20 minutes of, lecture didactics. And then some of the other patients like Jennifer and Cheryl are going to speak from their perspective. And we have tons of questions, Q&A, which I think is critical, because it's not what I want to say. It's you want to hear what your answers to your questions, and I get that. So let's get started. Granulomatosis polyangiitis, in the old days was known as Wegener's granulomatosis. At least from an ENT perspective, or head and neck surgery perspective, it's a disease of the respiratory tract. And I think that's probably the most important concept, just to understand why things happen and therefore how you deal with it. When I say the respiratory tract, I very mean specifically what's called the endothelium, or the lining inside tissues, inside your nose, inside the paranasal sinuses, inside the voice box or the lower half of the voice box, the windpipe or the trachea, the bronchi. This lining is called an epithelium, and it's a special kind of epithelium. It's called ciliated respiratory epithelium. Just like the mouth or the tongue has what's called a squamous epithelium, or your skin has a skin type epithelium, the respiratory tract has its own lining. And GPA and some of the other vasculitides, for example, Church-Strauss and microscopic polyangiitis and other diseases with not necessarily GPA, will attack this organ system, these respiratory tissues. Classically, when Wegener is actually a pathologist, he described autopsy specimens in the 1930s. The disease was noted to be in respiratory tissues and the kidneys, sinus, lung, and kidneys classically. You don't see it in the liver. You don't see it in the bones. Generally, you don't see it within the bone marrow and other organs. Now, everything I say is with a grain of salt. I'm going to say better than 95% of the time, but there's occasional outliers. But within the general concept, this is a disease of respiratory tissue. Now, why is that important? I told you about the nose, the sinuses, the windpipe, the trachea, the bronchi. It's important because these aren't the only tissues that have ciliated respiratory epithelium or respiratory tissue. For example, the middle ear space and the mastoid, which is the bone back here, which is like an air cavity pocket of reserved tissue and fluid that connects with the middle ear. Guess what? It's also a type of respiratory ciliated tissue. Cilia means these little bodies, these little like hair cells, which are constantly moving the fluids around. So if you think about it, if it's targeting this type of tissue, it's not a crazy inference to say, well, maybe GPA Wegener's can also attack the middle ear space of the mastoid. And guess what? It does. Other organ systems, the tear ducts. The tear ducts have a ciliated epithelium. So that's why some people end up with tear duct dysfunction or dacryocystitis. So if you think of this disease as an immune system now being overactive, dysregulated, targeting this tissue, well, then everything all of a sudden makes sense. For example, something primes this tissue, it becomes inflamed, it gets red, it does its thing, it causes certain immune cells to come together, and then they clump, and then the blood vessels get inflamed, and they die, and the tissues die, and we see this as clinical disease. So I think the first point to realize is that this is what's targeted, and the kidneys are a separate process within it. And we won't go there why now, right now. But then think to the next slide here. So we're going to treat it. How do we do this? We suppress the immune system because the immune system is we can still hold back on the old first slide first. The immune system is dysregulated. For practical purposes, it's overactive. Some diseases, the classic one, years ago was AIDS, was where the immune system is suppressed. It's weak. Here, your immune system is overactive. In fact, the whole field of rheumatology is on some level the study of an overimmune, overactive, dysregulated immune system that happens to target different organs and different systems. So in that sense, if the immune system is overactive or hyper, so to say, the treatments, at least the medical side of it is, we suppress the immune system. The classic drug was prednisone. I'm sure all of you here are familiar with it on one level or another. I'm sure it's a love-hate relationship. It's a very good drug. It's a very potent drug. I often tell patients it reminds me of the old Faustian deal. I don't know if those who don't know the story of Faust, he was the guy back in the 16th century who supposedly sold his soul to the devil, and he's going to have 7 great years, and then the clock strikes 12, and Faust is stabbed. My whole point is you get a lot of great symptoms relief up front, but with prednisone, there's a long-term price to pay. And that's important that you never forget that, and that the doctors who treat you don't forget that. So now if you think of the disease as targeting the respiratory tract with inflammation, what I often tell patients now is you have these organ systems or this lining that's on fire. And you have to ultimately separate two things, which we see on the bottom here. What is the fire? What is active disease? What is these autoimmune process out of control? And whether it's mediated with ANCA, pushing certain immune cells to come in, causing vasculitis, and therefore the little small vessels to necrose and the organs to die. We don't have to get that specific, but think of it as there's a fire in the system now, and we're bringing in one of those spray things like a fire extinguisher, except this is done systemically. Classically, it was done with cyclophosphamide or Cytoxan and prednisone. We almost never use Cytoxan today. It's also a very good drug, very potent, but that drug comes with a lot of side effects with Cytoxan, and they're better drugs now. And I'm sure those of you who are on board with all this know how useful rituximab or Rituxan is, and that for practical purposes, it's been a game changer over the last decade. So the next thing we have to consider is, again, you have a fire in this caused by this dysregulated or hyperactive immune system involving this respiratory tissue and different organ systems in the body. The fire has to be put out. And again, I leave that to the real doctors, the smart doctors, the rheumatologists. They have protocols from different types of monoclonal antibodies. By the way, anytime you hear a drug that ends in the word MAB, like rituximab, that stands for monoclonal antibody. These are certain biologics that are made to modulate and mess with the immune system. The second thing to realize, and that's I think the last point here in this slide, is that as an ENT surgeon, I have to often differentiate between what's active disease, when you think of it where the fire is burning, versus, okay, now the fire is over and you go into this house where there's smoke and there's destruction and you could smell the burned wood and you don't know what structure's intact, if it's safe, if it's not. I like that analogy. And then you have to go into some type of reconstructive mode if possible. So that's sort of how I like to look at it. On another practical level, sometimes there are elements of both. Disease could be active, it may not be active, but sometimes they use the term smoldering, where there's still some embers burning somewhere, or it's very hot and it's easy to reignite this process. But as a doctor, for me, most patients come to me pre-diagnosed. So in that sense, my job often is to tell the rheumatologist or the lung doctor or the kidney doctor, the immunologist, is it active? Is it secondary elements of both? And sometimes you don't know. I want to tell you all one thing. If you want to be a good doctor, be humble. It's a very good attribute. So let's go to the next slide. So the purpose of this lecture, as I was asked, is to deal with the airway. And for our purposes now, we're going to talk about the airway as being not in the ear, not in the nose, not in the paranasal sinuses, not even in the upper part, but really from the voice box, also known as the larynx, the trachea, also known as the windpipe, and the big bronchi. As you go down the bronchi, much lower in the airway, you get to what's called the lower airway and the alveoli. And physiologically, that's where air is exchanged. It's carbon dioxide out, oxygen in, and that's really the business of respiration. And the airway has multiple functions, but on a simple level, again, you have to, it has to be simple so that even I can understand. And if I can't make it that it's simple for you to understand, people sometimes are a little bit highfalutin, and I don't like that. The whole point here is to move air in and out, to respirate. In goes the good air, out comes the bad. More oxygen comes in, more carbon dioxide goes out. On a simple level, it's really that simple. The arithmetic or the number-based way of dealing with this is something called the minute ventilation. But it's called the quantitative assessment. And the lung doctor may send you for something called pulmonary function testing, and there are different types. But ultimately, it's sort of like an audit of your respiratory tract. There's different qualities, there's different numbers. And just like when we all do our tax forms at the end, there's one bottom number at the end. Well, in my view, the one bottom number is this thing called the minute ventilation. That is the quantitative measure of the, not so much the efficiency, but of the result of your ability to breathe. Now, why is it important? Because breathing is not overrated, and bad GPA affecting the voice box, the windpipe, or the bronchi will affect breathing, will affect your minute ventilation, and that's just not compatible with life. The amount of narrowing or obstruction varies depending on the severity of the disease. So the more narrow, and think of the upper airway, the larynx, windpipe, and bronchi. These are like pipes. Just like the pipes in your house might move water, these pipes have to move air. They have a structure based on cartilage to support them, a lining on the inside, this respiratory epithelium, to move and secrete these secretions, which let out chemicals called lysozymes and other kinds of enzymes, which help clean and repair this whole area for you. It's a beautiful physiological mechanism to watch mucus bring stuff up in the lung. By the way, we make about a quart every day. So if you have a small narrowing, for most people, it doesn't matter that much. The reason is, unless you're an Olympic athlete and you want to qualify, for most mortals, it becomes a meaningless thing. But as things narrow, they begin to become a problem. And for those of you who are more mathematically inclined, I told you before about this thing called minute ventilation. Minute ventilation, as I say, is the bottom line, and it's a function of several things, which is really the number of breaths and the airflow, how much volume of air moves in and out per minute. So, okay, you have decreased airflow because it's narrowing, but there's a tremendous leverage here that people don't realize. And I won't get into the physics of Boyle's law. For practical purposes, airflow is a function of the fourth power of the radius. And again, if you're mathematically inclined, that is not massive. That's unbelievable leverage. Let me give you an example. 100% of your minute ventilation has to go between your voice box and what's called the carina, where it splits into a right and left side of your lung. So for practical purposes, about 50% go to the right and 50% go to the left. However, 100% of this minute ventilation has to go through the voice box, larynx, or the trachea, the windpipe. And let's assume the most narrow portion of this windpipe is an area called the subglottic larynx. And I don't want to argue exact numbers, but your typical average-sized adult male, let's say the most narrow portion is about 8 millimeters. Well, it's 8.5, 7. You get my point. Let's say about 8, because it's also an easy number to work with. If you narrow from 8 to 4 millimeters, what's happening now is you cut the volume, the cross-sectional area by half, and your airflow is going to go down. But if all the other parameters are stable, what's going to happen now to your minute ventilation? Let's say you're moving 4 liters of air a minute. It does not go down by a half. It's going down to the fourth power. You're going to get 1/16 of the minute ventilation. Think about that. So instead of 4 liters, you're getting, well, let me do it quickly in my head. So 25% would be 1 liter, 16. So you'd be getting about 0.6, 0.7 liters instead of 4 liters of minute ventilation if the airway goes from 8 to 4 in this hypothetical example, which is really not that far off from most human beings. So what do? Well, many of you know the answer. You can compensate in several ways. The first is you breathe harder, right? If you have more pressure, more force, that will increase the airflow and bring back up your minute ventilation. It's like increasing the voltage in your electric system when the power is dropping. It's one way of getting more energy. It's either amperage or voltage, so you're pushing the voltage. So that's one way of doing it. But when you have to breathe harder, what does that mean? You're spending more metabolic energy, because in order to breathe, you have to burn glucose. You have to use oxygen, which means you need ventilation. So breathing gets a little harder. Now, what else do people do? Well, if the airway's tight, you do what other people do. Instead of running up the flight of stairs, you walk up the flight of stairs. Or if it's getting even worse, you don't walk up the stairs and you start spending less and breathing harder. And as the airway narrows, again, I'm talking about the larynx and the trachea because that's the point of 100% of your minute ventilation. What's going on now is you're getting this collapse, which is getting more and more substantive. And for practical purposes, in this person I told you about, the hypothetical adult male, probably between 4 and 3.5 millimeters, you start becoming symptomatic. Now, the thing is, you go from 4 to 3.5, you're symptomatic, but you may go from 8 to 4 and not be that symptomatic. But just think what happens now when you go from 3.5 to 2.5. You may be gasping for air. If you go down to 2, you may end up in the emergency room and someone will say you need a tracheotomy, you need to be intubated, you need some type of procedure. So in the sense, this could be the airway issue that many of you have been experiencing. I don't know if that's the case. It's a large audience. I'm grateful for that. But now you have a pipe that is not moving air. So we have to call Drano or whatever, the plumbing services, whatever you have. Sometimes I joke that I'm a plumber. So here you see now several options for opening up the airway. Now, this may be in the context of active disease. It may be in the context of inactive disease with scarring and after the effects, or it may be in the context of some blend between the two. The classic technique for somebody who is really sick and in dire needs is a tracheotomy, which is a breathing tube right through the second or third tracheal ring. It bypasses the larynx. It has a tube that has a nice sized airway and it goes down, usually towards the trachea, usually bypassing a lot of the obstruction, and people will breathe great. Plus, your minute ventilation goes up tremendously for other reasons. You get a kick because you have less dead space, but that's more for the lung doctors to deal with. Okay, trach works, but I think most of you don't want to have a tracheotomy. In fact, I spent half my career trying to safely, and I stress the word safely, get a trach tube out of someone. And sometimes you have no choice. It could be life-saving, and that's fine, and people can be comfortable with it. And if they're happy with it, in my view, that's a perfectly reasonable or rational decision on the part of an informed patient, and you don't burn any bridges. You can always change your mind later. So that's one way of securing an airway. Also, an emergency in the emergency room, sometimes an anesthesiologist will put a breathing tube in there, which is known as an endotracheal tube, but that's a temporary thing, really to stabilize so you can get more experienced eyes and hands on the patient. Dilations is a general type of term for opening up or ballooning open up the airway, and there are different ways of doing it. There are dilators. There are these tracheal balloons. They're similar to what the heart doctors use when they do a balloon angioplasty, when they have a coronary artery, one of the arteries in the heart that's clogged. They use different types of dilation techniques. Sometimes we do what's called radial incisions, where I actually make cuts into the scar tissue to release some of the tension or scar bands that are there. Some people use lasers, which are intense focused heat, specialized. I think of them as like a hot knife. At least in my hands, and vasculitis patient doesn't work. I have my thoughts why, but that we could talk about another time. Cryotherapy, which I do a lot of lately, is the opposite. It's freezing therapy, where you get things down to minus 77 degrees Celsius, and that can help prevent rescarring. Other ways of repairing the airway, and that could be larynx, trachea, or big bronchi, is open repair, where you make cuts. Sometimes you remove diseased tissue and do an anastomosis, putting them together. The other options are taking a piece of rib or some other type of autologous tissue, meaning from the patient themselves, and use it to make the airway itself bigger, put a stent in and line it with something, And one of I think the most exciting things now is the regenerative medicine, where we're looking to see how we can put new tissues. Actually, one of the reasons I changed my position, I moved to this hospital in New Jersey, is I'm going to work with a chest surgeon I know well. What we're going to do is we're going to build a lab where we've done some research in the past. I've operated with him on about 30 pigs, learning certain types of techniques where we can put in basically certain types of scaffolds to tether up the trachea, and we've impregnated them with stem cells in order to grow and regenerate. This is a new area in medicine. It's not only applicable in ENT and head and neck surgery or thoracic surgery, but in many areas of medicine. People talk about regenerative medicine, like making pancreas tissue in order to treat diabetes mellitus, or hepatic cells to treat liver failure. So this to me is sort of like the future, sort of the what we have to look forward to, hopefully. But ultimately, all these things are targeted to repairing the airway, allowing air to flow up and down, in and out comfortably, so patient breathes and the minute ventilation is established. So this was sort of what I do, why I do it, how it applies specifically in patients with GPA. I know we have some patients themselves who have a story that goes along those lines, and I hope I wasn't too technical. I try to be speak more in the vernacular that I would understand, if I'm simple. And hopefully we'll look forward to Q&A. And I just thank you all really for being here and listening. And if I can help, ask questions, you can call my office. If you don't come to New Jersey, I'll speak to you on the phone anyway. That's part of our job as physicians. I want to thank the foundation, Ed Becker, Kathy, Jennifer, everyone for this opportunity and this honor.
Well,